All right, good afternoon, everyone. Can you guys hear me okay?
I can.
Great. So I think we should get started. So the lecture for today is all about the brain rhythms and epilepsy. We have an hour to go through this lecture today. And it's mainly divided into three parts. So we've got the brain rhythms and EEG. We've got epilepsy and seizure. And also towards the end, we're also going to delve into sleep as well. So a lot of content to get through. So I think we should get started now. All right, so the first part of the slide looks at the objectives that we have for this session. So in this hour, our objectives is to make sure that we understand and able to discuss the basis of brain rhythms and electroencephalography, describe the International 1020 system, explain the primary frequency bands recorded by an EEG, discuss the behavioral and conscious correlates of brain rhythms, discuss the nature and types of seizures in epilepsy, discuss the correlation of seizure, epilepsy, and EEG, and why these are important to understand, and also discuss treatment options available for epilepsy. So before we delve into the more complicated parts of this lecture, I just want to take you through the basic introduction of this topic. So as you may know, our brain is works in a way that it's always activated. So whether we're sleeping, waking, hibernating, breathing, walking, we're always going to have electrical rhythms in our cerebral cortex. We spoke about the basis of the generation of the membrane potential 2 weeks ago. And these are the electrical rhythms that we detect in our cerebral cortex. The way we study the electrical potentials that are being generated in the brain is through the concept of electrophysiology. And one of the devices that we use, particularly in detecting changes in membrane potentials in the cortex, is through the use of a device called electroencephalography. Okay. So EEG is measured by non-invasive surface electrodes, which are placed on the scalp with a paste to ensure that there are low resistance between the surface of the skin and also the electrode. One thing to note here that's not depicted in the slide is that prior to placing the electrode on the scalp, it is important to wipe the area with an alcohol swab, just to make sure that there are no dead skin cells that can interfere or introduce external artifactual signals into the EEG trace. So the EEG measures or the distribution of the electrodes in the scalp is done in different regions of the brain. So from the frontal, parietal, temporal, and occipital lobe, you have a wide variety of electrodes that are being placed in these different areas. So in the next slide, you can see the distribution of the electrodes according to the International 1020 system. So the International 1020 system is a standard that has been established so that we can acquire uniform electrode coverage of the entire scalp so that if we are going to compare an EEG result from one individual to the next, we can actually compare the signals that we see from different individuals. Now, just a little bit of trivia for you guys. The reason why it's called the International 1020 system is because the fractions that you use to measure the distance between one electrode to the next is either 10% or 20%, okay? So hence the International 1020 system. So when you're trying to implement the 1020 system, it is important to note that you're measuring from the nasion to the inion. So the nasion is the bridge of the nose, and the inion is the groove that you have in the occipital part of your skull. Okay. In addition to that, you also measure the distance between the midline of your right or left ear to the other side of the ear, so that you could also measure distance in these areas over here. Okay. The following slide just looks at an example of a normal electroencephalogram that you can get using an EEG. So the trays, you can see that they are from different channels from the electrodes that were placed on the skull. Things that to note here is the different brain rhythms that you can actually acquire from the EEG trace. So in this case, you've got alpha rhythms, and you also have beta rhythms as well. So the difference between alpha rhythms and beta rhythm is that you have a higher amplitude with alpha rhythms as opposed to beta rhythms, which are lower in amplitude but higher in frequency. One thing to note here is that when you're using an EEG, it is important to note that you can either have internal or external artifacts that can occur. In some cases, you can have cardiac artifacts, which is the electrical signals that are being generated in the heart that allows it to contract. But you also have ocular muscle artifacts as well, such as the link artifacts that can interfere with your signals as well. And in terms of the external artifacts that we can get in an EEG trace, that involves the use of corroded electrodes that can interfere with the signals, and also not wiping the area clean that can add more resistance to your signals. So the concept of the signals that you get from an EEG is based on the change in membrane potential within the neuronal cells. So we know that cells can be divided into two, depending on whether they're excitable and non-excitable. And in terms of excitable cells, these are the cells that can actually generate an action potential through the change.
I just accidentally put my camera on.
Yeah, that's fine. All good. So yeah, you have two different types of cells. You've got the excitatory and non-excitatory cells, and neurons and muscles in particular are examples of the ones that are considered excitatory that can generate an action potential. So when neuronal cells within the cortex synchronize and fire action potentials at the same time, these signals are actually detected by the surface electrode of the EEG, okay? It is important to note that as the signals propagate towards the surface of the skin, most of the signals are actually lost through its propagation through different layers of the meninges, the skull, and also the skin layer in the skull as well. So what they normally do within the setup of an EEG is that they have an internal amplifier that allows for the signals to be amplified so that it's readable in an EEG trace. So this is just the slide showing you guys the synchronous firing of the EEG. Okay, so when you have a synchronized firing of the EEG, these signals actually sums up, which gives you a reading that can easily be read by an EEG. So the basis of the synchronous rhythm is the fact that we do have a central clock and a pacemaker within our nervous system that allows for neurons to fire at the same time. Okay, and in this case, you have the structure called the thalamus that is responsible for that. Okay. So as I mentioned before, the thalamus acts as the pacemaker in the brain, and the thalamic neurons can essentially generate rhythmic action potentials that is propagated to the cortex, which tells the cortex when to fire. The next bit is just looking at the device called the magnetoencephalography. So unlike the EEG, magnetoencephalography or MEG doesn't use the electrical potential in the brain, but they use the magnetic field that is being generated in the brain that are associated by the neural activity. And the flow of the magnetic field is generally defined by the right-hand rule, which is generated when there's an electric current that flows in a given medium, in this case, within the neurons. Of course, the use of an EEG or the MEG has its own advantages and disadvantages, okay? And looking at the points here, they're just showing you guys what is associated with the use of the MEG, okay? So in this case, MEG localizes sources of neural activity better than in EEG. So what this means is that it has a better spatial resolution than an EEG, because when you're using an EEG, if you're hooking it up in your frontal cortex, you don't really see which part of the frontal cortex is associated with that EEG trace, okay? So it doesn't have that specificity. However, if you're using a device like an MEG or even an fMRI or a PET scan, they have pretty good spatial resolution, okay, that allows you to pinpoint which areas of the brain are activated for a specific behavior. With that said, if you're comparing MEG to neuroimaging, like the functional MRI or a PET scan, the MEG fails in comparison in terms of generating detailed images of the brain. Therefore, although the MEG has a better spatial resolution than an EEG, it doesn't have a better spatial resolution if we compare it to a functional MRI or a PET scan. Okay. The advantage of using an EEG and MEG as opposed to the neuroimaging is the fact that it has a better temporal resolution, which means that they do acquire information faster than a PET scan or an MRI scan. And in addition to that, the signals that you get from this device measure the neuron activity directly, okay? On the other hand, if we look at the fMRI and PET scan, the information that they acquire is mainly associated with measuring the metabolic activity in neurons, which in this case is associated with increased in blood flow and metabolism. So where, for example, where glucose is being metabolized in the example of a PET scan. So some of this information is what I've alluded to previously. So as I mentioned before, when there's an electric current flows in a given medium, usually a magnetic field is generated, and this can be defined by the right-hand rule. One of the take-home messages from this slide is that it is important to note that the magnetic fields that is generated within the biological system is very low. It ranges from the femto to picotesla. So the measure of the magnetic field is Tesla. And if you apply, the femto and the pico level, it's about 10 to the minus 15 or to 10 to the minus 12. So it's a very low in terms of magnitude. Therefore, when trying to implement a MEG, it is important to note that it is actually done in certain ideal situations wherein it needs to be conducted in a specially shielded room that's free from external disturbances that can interfere with the collection of those signals. Okay. All right, so the image that you can see on the right-hand side of the slide is the images that you can see that you can acquire from the MEG. Okay, so it's very good at localizing specific areas where there's high activity. Okay, but it is important to note that it is not as detailed as neuroimaging such as fMRI and PET scans. Magnetoencephalography has been shown to be to be used in specific diagnosis of epilepsy and also language disorders. So moving on to the next section, and going back to the EEG, when you're trying to view an EEG trace, you could see that the brain waves that is generated, that is being displayed in an EEG trace can be divided into 4 main parts. So you've got beta, alpha, theta, and delta, and they are mainly separated by their frequency. So as you can see on this slide, delta is characterized by wave deflections that are about 4 hertz. So it's going to be the slower wave here. Okay. And theta, it's about 4 to 8 hertz. Okay. So it's slower than both alpha and beta, but it is faster than delta. Alpha, on the other hand, is characterized by having 8 to 13 hertz, and beta would be 13 to 30 hertz. And one thing to note here is that these brain rhythms have been associated with different types of behavior. So in this case, when you have an activated cortex or attentive cortex, what you normally see in your EEG trace is that you have mostly beta activity. When it comes to having a more relaxed mind frame, you would see a higher level of alpha in addition to beta. When you're having a drowsy state, it is associated with theta activity. And when you're in deep sleep, it is associated with the delta activity. Okay. One thing to note here is that if you guys ever had the opportunity to use an EEG in any of your lab class, and when you're trying to achieve alpha rhythms by asking a participant to actually relax their state of mind, it is important to note that alpha is really difficult to actually pull off. Even if you ask your participant to kind of, relax their state of mind, you can still see a lot of beta activity in your EEG trace. Okay. All right. So clinically, consciousness can be graded into 4 different parts. So you've got alertness, and then followed by drowsiness. Then you have the stupor. So the stupor is a state of mind where you're close to unconsciousness with less reactivity to a specific stimuli. And the last part is the onset of coma. Okay. It is important to note that alertness is the most active state of consciousness. So in this case, when we're talking about having a lot of beta activity, this is mainly seen in this state of mind. And as you go down, the EEG activity slows down. It is important to note that brainwaves can change according to specific factors. So in this case, you have age, sensory stimuli, brain disease, and also chemical state. Okay. And usually cerebral function is disrupted when brain waves are too fast and too slow. So in this case, when your brain waves are too fast, it can often lead to the onset of unconsciousness. And at the same time, when the cerebral cortical function is too low, this can also lead to the onset of unconsciousness as well. When we're talking about cerebral cortical function becoming too slow and eventually leading to a flat EEG line, this is mainly associated with the onset of brain death, okay? And brain death is usually observed for at least 3 to 4 hours using an EEG. With that said, it is important to note that when you're trying to diagnose somebody with brain death, although EEG is one of the assessments or diagnostic tool that you use, you actually perform other activities to confirm this diagnosis. So the next bit is looking at seizure and epilepsy. So epilepsy is a neurological disorder that is characterized by the onset of repeated seizures. Seizure, on the other hand, is defined by the abnormal behavior caused by an electrical discharge from the neurons in the cerebral cortex, which leads to specific signs and symptoms that can vary depending on where these abnormal discharge are coming from. So 2 weeks ago, we've spoken about different areas of the brain being responsible for different functions of the body. So depending on where the seizure actually takes place, it can either lead to sensory manifestation, motor, autonomic, or psychic phenomena. The most common example that we know of a seizure is a type of motor seizure that involves jerking of your extremities, okay? And this is mainly defined as a convulsion, okay? So we've defined seizure as a abnormal behavior caused by abnormal electrical discharge from the neuron in the cerebral cortex. And it has been postulated to be associated with disturbance in the change in membrane potential within each cell. So it can be associated with alterations in cell membrane permeability, distribution of ion channels that facilitates this, and also decreased inhibition of cortical or thalamic neuronal activity within the brain. And lastly, you also have the neurotransmitter imbalances. So in this case, when you have an increase in acetylcholine, which is released from excitatory neurons, it would be associated with more seizures as opposed to having an increase in GABA activity, which allows your brain to actually balance the discharge and the inhibition of these excitatory neurons. What they've shown is that when individuals have are at high risk of the onset of seizures and eventually epilepsy, they tend to have or express more acetylcholine and also paired with a decrease in GABA activity. So they are in a situation wherein their excitatory neurons are reinforced, but at the same time, their inhibiting neurons are actually decreased. That leads to an abnormal discharge of neuronal activity in the brain. So, as I said previously, seizures are due to the imbalance of synaptic excitation and inhibition in the brain. So in this case, you have more neurons that release the acetylcholine and less neurons that inhibits the excitatory neurons that through the release of the GABA neurotransmitter. So in this case, when it comes to generating a treatment for seizures, they tend to use anticonvulsants, which are medications that prolongs the inhibitory actions of the GABA neurotransmitter. So an example here would be the use of barbiturates, benzodiazepines as well. Okay, it has been shown that the use of medications that block GABA receptors, okay, that reduce the inhibition of excitatory neurons tend to be considered as strong convulsants. So these are seizure promoting agents. So more studies were done in epilepsy, just trying to define what are the factors that lead to the onset of this condition. And they've shown that there are genetic correlations when it comes to assessing the risks of individuals with epilepsy. And in this case, what they've shown is that usually patients with a high risk of developing epilepsy would have mutations of genes that encodes for sodium channel proteins. So if you guys have link it back to the introduction lecture that we have, we know that sodium ion channels contributes to the change in membrane potential within a neuron by allowing sodium ions to flow into the cell, which makes the cell more positive. Okay, so in this case, you have these mutated sodium ion channels that tend to stay open longer than normal. Okay, so it allows for more action potentials to be generated. There are also evidence to show that gene mutation has also been linked to impaired synaptic inhibition mediated by the GABA, which doesn't allow our brain to have a balance of excitatory and inhibitory activity. Okay. So when you're looking at a seizure activity in the brain, one of the things that you notice is that it shows an EEG trace with low frequency and high amplitude. Okay, so it tends to be associated with slow waves. And seizures can be classified into three main parts. So you've got the generalized seizure, which affects the entire cerebral cortex. And you have a complete behavioral disruption because it covers the entire cortex. It tends to be associated with a loss of consciousness as well. When you only have a small area affected in your cortex, this is associated with the onset of partial seizure, okay? And depending on where this seizure actually takes place, you can either experience motor disruption or sensory disruptions. And lastly, you've got the absence seizure, which is characterized by having 30 seconds of generalized seizure, and you have the synchrony of these signals into 3 Hertz EEG waves, and these are mainly seen in childhood individuals. So as I said previously, you have generalized seizure, which covers the entire cortex. And in this case, it involves both hemisphere. It leads to the following symptoms. So you've got the disturbances in consciousness, loss of muscle tone, slack jaw, drooping of limbs, and falling. You have the myoclonic effect where your muscles actually contract and relax. And this is what you can see when somebody's having a convulsion where they're swinging their arms uncontrollably when they're having their epileptic fit. Okay, and lastly, you've got the tonic-clonic effect where you have muscle contraction followed by the loss of consciousness as well. So before we finish up with talking about the neurological basis of seizures, I'd just like to point out the extreme version of epilepsy, which is called the status epilepticus. So this is when seizures can last longer than 5 to 20 minutes. And it is mainly characterized by the onset of repeated seizures without recovery between them. And because this can last for 5 to 20 minutes, it has been known that if this is untreated or not stopped, this can usually lead to the death of that individual. In terms of how they treat this extreme case of epilepsy, there are 3 main line of therapies that people actually follow. The first one is the treatment of that individual using benzodiazepine. If that doesn't work, they go through the second line of treatment, which is the use of phenytoin. And the third line of treatment there, if it's very severe, they tend to use the phenobarbital, which can induce a coma in that individual. Okay. Looking at these different medications that are being used in someone with status epilepticus, it is mainly associated with decreasing the excitatory effect of the neuron by depressing the central nervous system. So the next slide just looks at the example of a absence seizure and what you can see in your EEG device. So as you can see here, you've got the scale here. So it's about a 12-second wave that you can see associated with the absence seizure. So usually it starts abruptly. And when you have the synchronous activity of the abnormal discharge, this can actually sum up into a 3 Hertz wave that can last for about 12 seconds. And after that, you have the normalization of the EEG trace. Okay. In terms of the symptoms that you can see in someone with an absence seizure, you normally would have specific motor signs that is characterized by fluttering of the eyelids and also twitching of the mouth. And when you're observing someone with that had absence seizure, they tend to not have a recollection of the event. And this is because when you're having these activities, it tends to lead to the onset of unconsciousness. All right, so the next bit is looking at temporal lobe seizures. So this is an example of partial seizure that is mainly confined in the temporal lobe. We know that the temporal lobe is associated with the processing of olfactory and gustatory information. So when you have seizures in this area, it usually leads to olfactory and gustatory symptoms and has an effect on visual distortions as well. In addition to that, when you have partial seizures originating in the motor cortex, which is part of your frontal lobe, this tends to lead to the onset of the myoclonic symptom, wherein you are producing focal motor jerking. And lastly, if we're talking about occipital lobe seizures, these are associated with the onset of visual symptoms, mostly defined by the onset of flashing lights or the perception of flashing lights. All right. So the next part is looking at epilepsy and how it is manifested in sleep. It is important to note that 10% of seizure patients have only nocturnal seizures without daytime seizures. As I noted previously, when you have an epileptic individual and when during the onset of this attack, you normally would have an EEG trace that depicts slow wave activity. Therefore, the onset of epilepsy in this situation is seen in slow wave sleep. Okay. There is a section in your sleep called the rapid eye movement. And this part of your sleep is tend to be protective against the onset of epileptic form. Okay. All right. So the next bit is looking at the onset of nocturnal paroxysmal dystonia. So this is associated with the onset of a frontal lobe seizure that occurs during non-REM sleep, which is characterized by dystonic movement of extremities in-body access, automatisms, affective mimics, and vocalizations as well. Okay. In this situation, the medication preferred to treat this condition is the use of carbamazepine. So when we spoke about the use of the status epilepticus earlier, I alluded to certain medications that can be used as a first line, second line, and third line therapy. And some of these examples are also noted in this slide. So when you have someone with epilepsy, you tend to treat them with the use of benzodiazepines, okay? And also phenytoin, depending on their situation. In extreme cases, you tend to use phenobarbital to induce a coma to prevent the debilitating effects of status epilepticus, for example. These medications have their own mechanisms. In this case, when we're talking about benzodiazepines and phenobarbital, it is associated with the enhancement of the GABA-mediated inhibition. So again, it is ensuring that the inhibitory neurons do their job in trying to maintain homeostasis in the brain. If we're talking about the use of phenytoin, it is mainly attributed to the fact that it is an effective sodium channel blocker that prevents neurons from generating an action potential. In other severe cases with an individual with epilepsy, there are surgical therapy that can be done. Surgical therapy is associated with removing certain parts of the brain, especially those that have been affected by the onset of epileptic lesions. Okay, but because of the invasive nature of this treatment, the best way to treat the onset of an epilepsy is through the use of different medications first. Okay. In some cases, some physicians have looked at the use of implanted electrical stimulation of the vagus nerve, which has been shown to help manage the onset of seizures as well. All right. So to finish off this lecture, we have about 15 minutes. I'd just like to speak about sleep and its mechanisms as well. So you have your objectives here. And just for the interest of time, I'm not going to go through each one of them. But if you guys would like to kind of define what you guys need to take away from this lecture, this is a good way to actually look at that. Okay. So just a quick introduction about sleep. So sleep is a behavior that is universal among higher vertebrates. And I don't know about you guys, but I like my sleep. So any sleep deprivation, it tends to be devastating, okay? Which affects you functionally, not more so physically. I don't know why my slide is activating, shifting on its own. So the definition of sleep is that it is a readily reversible state of reduced responsiveness to and interaction with the environment. So when studying sleep, you tend to use a collection of devices called the polysomnography. And polysomnography is a collection of devices with the use of an EEG to monitor brain waves, EMG, which measures muscle activity, and EOG, which monitors ocular activity. You also have the use of respiration and temperature devices as well. Okay. In this diagram over here, you tend to see the application of these different devices on that individual, which allows you to get the physiological readings that you need during sleep. So our understanding of sleep has changed over time. So you've got the classical definition of it, which was defined by in 1968. So in this case, you've got different stages that were defined, from wakefulness to non-REM sleep, which is divided into 4 categories, from stage 1 to stage 4. And you have the onset of the rapid eye movement. Since then, in 2007, they've revised this definition and changed it a little bit by removing stage 4 sleep, stage 4 non-REM sleep. And the reason for this is because they didn't really see any physiological or clinical basis for the difference between stage 3 and stage 4. Therefore, they've simplified this by dividing non-REM sleep into 3 stages, from stage N1 to stage N3. This slide just gives you an idea of how EEG is applied in the onset of sleep, okay? So if you look at figure B, you could see the different EEG waves that you can see from different state of consciousness. So you've got the awake condition. In this case, you can see mostly beta rhythms and also alpha rhythms in this stage. When you go to a REM sleep, you would have a similar sort of EEG trace, okay? And what we know about the REM sleep is that it is the stage of the sleep where you're actually experiencing dreams. Therefore, it is expected for your brain to actually have an active cortex, okay? When you're going through the different stages of non-REM from stage 1 to stage 3, if we're referring it back to the classical definition of sleep, you tend to have slower rhythms with higher amplitudes. So in this case, in stage 1, it is mainly comprised of theta rhythms, but the later stages of sleep is characterized by slower brain waves, which is characterized by the onset of delta rhythms. The difference between stage 1 and stage 2 can be characterized by having specific deflections called the K complex and also the sleep spindles, okay? And that's how you tend to categorize between stage 1 and stage 2, which is abundant in theta brainwaves. So this is just a diagram to give you guys an idea of how different stages of sleep is associated with different physiological response, from eye movements, heart rate, respiration, and penile erection, okay? So from what you can see here, there are there is higher activity in the REM sleep as opposed to non-REM, where there is a reduced activity in these different physiological readings. The other thing to note here as well is that when throughout the course of the night, the non-REM sleep tend to be reduced as opposed to the REM sleep, which tends to expand as your sleep gets longer overnight. So the next bit is looking at the neural mechanisms of sleep. So you have critical neurons that is present in the brain called the diffuse modulatory neurotransmitter systems. And these diffuse modulatory systems are part of what they call the reticular activating system. The diffuse modulatory system are the noradrenergic, serotonergic, and cholinergic neurons, which have been implicated in the state of wakefulness. Okay. In this case, noradrenergic and serotonergic neurons fire heavily during enhanced waking state, and cholinergic neurons have been implicated in the onset of REM sleep. So in this case, in situations where you have an active cortex, these diffuse modulatory system have been implicated to be active. Okay. So again, this is just gives you an idea of the firing of these neurons and how they play a role throughout the course of sleep. Okay. So as I said previously, you have the reticular activating system that plays a huge role in the onset of wakefulness. Okay, so the different parts of the brain that are involved in this are called is the locus coeruleus, which contains the noradrenergic neurons. Okay, you've got the raphe nuclei, which has the serotonergic neurons. You've got the neuronal cells that secrete the acetylcholine, and you also have neurons that release the neurotransmitter called histamine. Okay. So as daytime goes by, and when you have an increase in the activity of these diffuse modulatory system, their firing rates normally decrease over time. And this is when the onset of sleep actually occurs, when the activity of these neurons actually decrease as the day goes by. So what they've shown is that just before falling asleep, you would have a significant decrease of these activities within these neurons that release norepinephrine, serotonin, and acetylcholine. And in situations where you're actually in non-REM sleep, then you have minimal activities of these neurons. Okay. Within the stages of sleep, some of the characteristics that you get would be the onset of EEG sleep spindles, which eventually will disappear. And when you're in stage 3 and stage 4, this is when you get prominent delta rhythms in your EEG trace. So as you go through the non-REM sleep, eventually you'll get into your REM sleep. So your neurons will get activated in this stage of sleep. Okay. And it has been defined that when you are experiencing dreams, this usually occurs when you are in your REM sleep. REM sleep, unlike the non-REM sleep, tend to have a paralytic effect. Therefore, when you're asleep and you're experiencing your dreams, you don't tend to act out your dreams, okay? Different structures that have been associated with the REM sleep involves the extrastriate cortex and portions of the limbic system. The limbic system is associated with the onset of emotional experiences. Therefore, when you are dreaming, you tend to have these emotional experiences integrated on it as well, okay? All right. So the next bit is looking at the neurotransmitter that is opposite of the neurotransmitters that are being released in the reticular activating system. So what investigators have defined is that adenosine counteracts serotonin, noradrenaline, and acetylcholine as a neurotransmitter that promotes sleep. It has been shown that the neural activity associated with the release of adenosine actually inhibits the activity of the reticular activating system. So when you have a decreased activity in these neurotransmitter, this is attributed to an increased levels of adenosine in the brain, okay? After your sleep begins, it is usually correlated by high levels of adenosine, but as your sleep goes through its cycles, the levels of adenosine actually slowly falls off. And in this case, you have a slow increase in your diffuse modulatory system activity, which leads to wakefulness, okay? The role of adenosine has been associated with your body's need of restoration. So it is an important neurotransmitter in mediating that effect. The next bit is looking at circadian rhythms. I know we're running out of time, so I'm just gonna run through this quite quickly. So circadian rhythm is our daily light and dark cycles, which controls our behavior and our sleep patterns. And the sleep patterns is usually governed by an area of the brain called the suprachiasmatic nucleus, okay? Suprachiasmatic nucleus is located within the hypothalamus and is considered as our biological clock and is mainly controlled by different factors. In this case, you have the Zeitgebers, which are the environmental cues. And the most popular Zeitgeber that we have is the detection of light through the ocular system. So in this case, within our eyes, we have photosensitive mechanisms to reset the brain clock. So as you take in more light, you tend to feel less sleepy, okay? So the next bit is looking at sleep disturbances. So sleep disturbances that we know of is comprised of sleepwalking and sleep talking. So sleepwalking is also called somnambulism. It usually peaks at about 11 years old. It has been defined that about 40% of children does sleepwalk. And in the onset of sleepwalking, individuals tend to have their eyes open. They walk inside or outside and have awareness to avoid objects. It is important to note that when you're dealing with individuals that are sleepwalking, they tend to be difficult to um, to change their status from being asleep to awake. Okay, so the best guidance in terms of trying to deal with somebody that's sleepwalking is to safely guide them back to their bed. Okay, and if you talk about this, you know, with an individual that sleepwalks, they tend to have no memory about the incident. Okay, so the next bit is defining sleep terrors. So sleep terrors is mainly common in children aged 5 to 7 years old. And it is mainly characterized by displaying screams in the middle of the night. And this is characterized or seen when individuals are in stage 3 and stage 4 of non-REM sleep. Okay. And lastly, just to finish off the lecture, so these are just the sleep orders that we know of. So you've got the narcolepsy. So these are the bizarre disturbances of sleep and waking, which includes excessive daytime sleepiness and sleep attacks. We have cataplexy, which is characterized by a sudden muscular paralysis while conscious. You've got sleep paralysis, wherein you've got the loss of muscle control. And lastly, you've got the hypnagogic hallucination, which is the onset of graphic dreams, often quite frightening and accompanied by sleep onset and may follow sleep paralysis as well. So apologies for going over time, but that's pretty much it in terms of this lecture. So if you guys have any questions in regards to the topic, feel free to reach out through my email. Yeah, you guys have a nice day ahead.